The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everybody, and welcome to this RSPCH webinar on sleep terror, why paediatricians can't ignore fatigue. Today's webinar will be presented by Dr. Michael Farquhar, consultant in sleep medicine at Evelina London Children's Hospital, and Dr. Cherry Alviani, paediatric trainee and clinical research fellow at the University of Southampton. If you have any colleagues that are unable to make the webinar today, we are recording it and it will be available in a few days after the webinar, and we'll send a link out. Also, during the webinar, if you have any questions, do submit them through the questions tab on your GoToMeeting, on your GoToWebinar screen, and we'll take questions at the end of the presentation. So without further ado, I'll hand over to Mike to start the presentation.
Cool. Thank you very much. So my name is Mike Farquhar. I'm a consultant in sleep medicine at Evelina London, and Cherry Alviani and myself are going to spend the next 45 minutes or so talking you through some of the things that we think the college has been doing and should be doing around about the issues of fatigue and well-being for our teams. To begin with, I'll just mention, so in addition to the questions via the app, if you're following this on social media, then there are also Twitter hashtags and handles there, so do feel free to comment on Twitter and carry along. What we're going to do over the course of the next 45 minutes, Cherry's going to run you through the work that we've been doing in the London School of Paediatrics over the last few years about this, and that will focus on both the work that we've done, but also the work we've done to survey trainees around the country as well as within London about how well that's working. And then I will then take on from that and talk about the things that I think we should be building that into. So I'll hand over to Cherry.
Thank you, Mike. So we first started looking at trainee paediatricians' experiences of fatigue and sleep during night shift in spring 2016, and this was through a survey of all London School of Paediatrics trainees. We had very good response. Over 10% of trainees responded, nearly actually 20%, representing all London trusts with an even distribution of training grades. The first thing we asked was how likely our trainees were to take a nap during a night shift, and sort of over 50% of trainees felt they never or were very unlikely to take a nap, and generally the average score was sort of 2.7 on a score from 0 to 10. We also wondered whether trainees felt that their departments were supportive of the taking of naps during night shifts, and the general feeling was that, sorry, we're just seeing if has it used. Sorry, we've had some Wi-Fi issues. So if I just go back, here we go. So looking at whether trainees felt the departments were supportive of them taking naps, and only about 16% of trainees felt that departments were supportive, 30% were aware that departments were not supportive, and many were not sure. We also asked trainees whether they felt there was a formal policy in place regarding this issue. Less than a third of trainees were aware of a policy in place, and all the policies that did exist were negative, so they were very unsupportive of nap taking. We asked whether departments or trusts provided them with suitable facilities to sleep during their night shift should they want to, and over 80% of trainees said there were no facilities. And by facilities, we didn't necessarily mean an encore room with a bed, we meant just a quiet, dark room where they could rest for 20 minutes should they want to. And finally, we wondered whether people had received any teaching or training relating to taking rests on night sleep and generally on sleep hygiene around shift work. And again, about 80% of trainees had had no training on this subject at all. So following this, the results were disseminated and they received national interest. They were published in the Health Science Journal, on the BBC Inside Out programme and in the BMJ News, and they were presented both locally to the London School of Paediatrics and widely through the RCPCH annual conference. We then subsequently decided to sort of help implement some changes. This was done through formal training, through ST1 induction, training. They were in a London induction and Guy's and St Thomas's Hospital induction. Mike wrote an article for the Archives of Disease in Childhood on sleep for your own health, and we'll talk about that again later. And there are now campaigns in place by the BMA, the Royal College of Anaesthetists and the Royal College of Emergency Medicine, helping doctors to address fatigue. We then, after all these changes were implemented, decided to try and repeat the survey with a dual purpose. One was to see whether this educational drive had any impact, and secondly was to obtain a more UK-wide paediatrician's perspective rather than just a London-focused one. So again, this was done through an online survey tool. It was disseminated to all UK paediatricians, including consultants, through the RCPCH heads of school, local training programme directions, and via link on ePortfolio. It was run over 4 weeks at this time last year, and we estimated that around 10% of the whole trainee workforce responded. So we had around 800 responses. And these were sort of quite evenly distributed throughout training grades, and about 10% of the responses also came from the consultant body. Most UK regions were represented. We again asked whether sort of pan-UK people had any exposure to education on fatigue and shift work, and results were similar to previous, so around 70% of people had had no education and no teaching. Of these, the vast majority felt that the teaching was very helpful and useful. The ones that didn't find it useful, the reasons were either because they felt it was too late in their training, or they found it very difficult to see how they could put into practice any of the suggested changes. Of the people that hadn't had any training, 90% felt that they would have benefited from it. What was very helpful to us was to see that of the people who did have some teaching or training on the subject, over 75% of them will change some aspect of their sleep routine, be it a change to night shift, a change of their core sleep routine, or both. So that suggests to us that actually delivering education on this topic does implement a change. We again asked whether people felt that their departments were supportive of taking naps, and this was really helpful to see that in London, where previously only 15% of departments had been supportive, now around 50% of departments were supportive, and pan-UK the figure was sort of closer to a third. And again, regarding facilities, unfortunately, this figure was relatively unchanged. So again, 83% of people had no access to any adequate facilities to rest should they want to. There was a free text comment which was widely used, and various themes emerged on the topics. A lot of people talked about how their departments weren't supportive, and it was generally always felt to be an awake shift at night and not a sleeping shift, how they felt incredibly tired, and there was a lot of elements relating to both patient and personal safety in terms of driving home tired or working when very tired. So in summary, this was a UK-wide survey of paediatricians' experience of sleep and night shift work. 70% of respondents who were given some form of teaching on the topic do change their sleep practices, but unfortunately, throughout the UK, 70% of our respondents had had no exposure to such teaching. An educational drive that so far had been mostly London-based had increased departmental supports of naps during breaks from 15 to 50%, but generally throughout the UK, adequate facilities in departments remain lacking. So I'll now hand over to Mike, who will talk to us a bit more about what changes have been put in place.
Thank you. So it's useful to go back a little bit and look at some of the background to this. So the survey that we did of UK paediatricians was done purely through Cherry's hard work, and I think the response rate that we got was one we were very happy with. However, around about the same time as we were doing this, there was a survey of anaesthetic registrars that was published in the Anaesthesia Journal last year, looking at the experience of anaesthetic registrars around about fatigue, particularly when working nights. A lot of the focus on this, and I'll come on to that in a second, is around about the fact that we know that if we ask you your experience of driving home, if you have to drive home after a night shift, that most of you will tell us that you have felt unsafe driving home at some points. And one of the key initial impetus for me to start doing this work is that about half of you report having had an accident or a near miss driving home, and it means that people are at risk of crashing and dying on the way home from night shifts. We need to think about that a little bit in the way that we have changed how we think about drink driving over the last 20 to 30 years. We are pretty much at a point now where campaigns like this are prevalent, and we've moved from an attitude that was a bit like this when I was a child, where as long as adults had only had a few pints, they were still okay to get behind the wheel of a car. So 4 or 5 pints, you'll be all right, away you go and drive. We are pretty much now at this point where we have a no tolerance attitude towards any alcohol when we drink and drive. What we know, though, is that when we look at the rationale behind that, so most people are not drunk by the time they've had the amount of alcohol that will get them to the drink drive limit. But what it does do is delay their reaction time sufficiently that it significantly increases their risk of having a major road traffic accident. When we look at other things that have the same impact on reaction time, the evidence around about fatigue tells us that for most people, once you have been awake for about 16 to 18 hours, your reaction time is going to be the same as if you're at the legal drink drive limit. Now, that data assumes that you have had the right amount of good quality sleep in the days and nights before that. Those of you who have worked night shifts will know that by the time you get to the 4th morning after 3 night shifts, you will have slept far less than you normally do, and the quality of that sleep is likely to have been significantly less, which means this threshold will be lower. So you are going to be getting to the point where you are trying to drive home after night shifts, particularly towards the end of runs of night shifts, where you're going to be getting behind the wheel of a car with your reaction time the same as if you're at the drink drive limit or worse. And that means that your risk of having an accident is just the same. And it means that we need to start to think about driving tired in the same way as we've thought about driving drunk over the last 20 to 30 years. It took a lot of time to change that attitude around about alcohol, and we're only at the very beginning, I think, about doing it from a fatigue point of view. One of the pieces of work that we have done to support this, we did a report with the BBC Inside Out South programme about a year and a half ago now, and this is a registrar from Oxford who was put in a driving simulator to simulate her normal drive home after a night shift. And although she makes it, there's no major crash or drama in the simulator. There are lots and lots of near misses, and every single one of those is the potential for a major problem, for a crash, for a death. It's a really good way, if you want to demonstrate to people how significant an issue this is, spending 10 minutes watching that report is a really good way to get that message clearly across to people. When we look at other data that comes from surveys that look at trainees' experience up and down the country, this is from the GMC survey, and this looks at workload intensity across different specialties. The key bits to look at from this is that the orange and light blue towards the bottom of each of these lines represents people who say their workload is very intense. When we look at anaesthetists on the left there compared to paediatricians, you will see that anaesthetists have far less orange and light blue, the heavy and very heavy intensity. And you guys report a much heavier intensity of workload than anaesthetic trainees do on average. But we know from the data from the anaesthetic survey that fatigue is having a significant impact on every aspect of their personal and professional lives. And we don't need to do the detailed survey to the extent that they did with you guys to know that you are likely to be experiencing at least the same impact, if not more, with the workload that you're doing. It is not quite as simple, by the way, as just workload intensity. Those of you who may be working in high pressure, high intensity specialties like emergency or intensive care will thrive to a degree on some of that intensity. So it's not quite as simple as the more intense, the more the problem. But I think it's enough of a comparison to say that if it's affecting the anaesthetist, we would expect it to be affecting all specialties. When we look at the consequence of fatigue and sleep deprivation, particularly around about working shifts, there's beginning to be a very overwhelming body of evidence that tells us this is bad for you. This is a really nice BMJ state-of-the-art review from a couple of years ago now, so you can follow the link at the bottom to get the detailed paper. But what it boils down to is this. In every aspect of your physical and mental health, we know that sleep deprivation is bad for anyone, and we know that shift work is even worse. So just by working shifts, when we ask you to do that, to provide the care that the NHS needs to provide 24 hours a day, 7 days a week, 365 days a year, your risk of type 2 diabetes goes up, your risk of obesity goes up, your risk of stroke goes up, your risk of Alzheimer's disease goes up. The evidence is slightly more mixed, but it's beginning to become clearer to tell us that your risk of some types of cancer will go up. So there is a very definite impact to your health just in asking you to work shifts and around the clock that we need to acknowledge and try and mitigate as best we can. And historically, we've been very bad about doing that. It also, though, has significant effects on the care that you are delivering to patients. This is a really nice study that was done by the team down in Southampton Children's Hospital, and it's a simple risk assessment exercise. They looked at the intensive care registrars in their PICU. They gave them this test at the beginning of a shift and the end of a shift. And what they had to do was press a button. The more they press the button, the bigger the balloon gets. The bigger the balloon gets, the more likely it is to pop. The bigger they get it without popping, the more money they get. And they did this experiment at the beginning of the night shift and the end of the night shift. It will not surprise you to find out that they made more risky decisions at the end of the night shift. More balloons popped and they got less money because their ability to judge risk is impaired when they are sleep deprived. When we look at the data from experiments like this, broader than this the single experiment, we know that the thing that doesn't change is people's confidence. So people remain just as confident making those risky decisions as they were making safer decisions at the beginning of a shift. And that clearly has consequences. It absolutely has a consequence. If you're trying to decide whether you're safe to get behind the wheel of a car to drive home, your brain is going to be telling you, yeah, it's going to be okay, because the bit of your brain that's making that assessment is impaired. If you were called to resus at 7:30 to deal with a fitting 5-year-old, the decisions, the assessment that you are going to make if you are fatigued is going to be inherently more risky than the decisions and management choices that you will make if you are not significantly fatigued. So this impacts on every aspect of everything that we do. A lot of what we've been trying to do over the last few years, so there's lots of things we've been trying to do, but actually the most important point boils down to this. We've lost sight a little bit in the NHS as a whole that we know it's getting really tough out there. It is phenomenally busy. The resources that we have to deal with what needs to come through the front door, the patients that need to be helped and managed, just doesn't match up. And you, all of us who are healthcare professionals, tend to be people who, when faced with a choice between stopping for 10 minutes for a cup of tea and going to deal with the fact that there are 8 people in the waiting room that still need to be seen, who've all been waiting for hours, you will all choose to go and help the patients before you look after yourselves. And that feels like the right thing to do on one level. The danger is, though, that you cannot sustain function and performance if you carry on working for 8, 10, 12, 13 hours without taking a break. Your performance is impaired. And what that means is not only do those risks to yourself increase, but it also means that the care you deliver to your patients is going to be less safe, less effective, and less efficient. We have forgotten that breaks are there to protect our patients just as much, if not more, than they are to protect ourselves. These signs, by the way, are up and down the A9 in north of Scotland, which is a beautiful road, but the people who drive it regularly tend to get a bit bored of it, and the long-distance HGV drivers used to be at significant risk of road traffic accident because they just ploughed on, literally, until they caused accidents. And these signs are to remind them that if they don't stop and take a break, then it's going to have consequences. Other industries are a lot better at doing this than we are. I think this is a helpful analogy to a degree. So the air traffic control tower at Gatwick should have 3 members of staff to run safely. An air traffic controller is only allowed to work for 2 hours before they must take a mandatory 30-minute break, because it is judged that their ability to sustain function and performance beyond 2 hours is significantly reduced. On this Sunday, it happened that 2 of them called in sick. They couldn't get replacements. There was one guy left to try and do the whole thing by himself. And the airport took the decision that the only thing they could do was to close the runways, redivert flights, cancel flights, to make sure that that single member of staff got his breaks, because otherwise they could not provide a safe service. We cannot close the runways in hospitals. We have to keep the front doors open. We have to keep the service running. But we have to be aware that other industries think about safety in this aspect much better than we do. And if we are not doing the equivalent of shutting the runways, we have to be making sure we're putting in place the appropriate compensations in other ways. This is the simple point of that. So you know that these appeared all the way through the junior doctors' strike, but it's a really simple point. It's so obvious, it seems silly to make it in many ways, but you know that if you are tired, you are much more likely to make a mistake. And we therefore have an obligation to try and do something about that, to reduce that risk of patient safety as well as the risk to yourselves. So what we've been doing over the last bit of time, initially within Evelina London Children's Hospital, and then expanding through the London School of Paediatrics over the last 5 or 6 years, is trying to think about what we can do better about that. The very first thing that we did, so shortly after I became a consultant, I asked to be allowed a slot in our teaching sessions at induction for our new trainees joining Evelina London. It took a bit of persuasion. Induction programs are packed full with all the really exciting and important things about bins and hand washing and fire safety that you must be told 20 times in your career. But we eventually managed to get a short slot. And what I did with that slot was to try and run people through the very basics of sleep physiology and what they could do to try and make it better. These slides represent an hour's talk summarized into a single slide. But the kind of things that we talked to our trainees about was how to improve their core sleep, how to make their bedroom environment as good as possible, particularly when they're trying to sleep in the daytime if they're on night shift, to make those as good quality as possible for good quality sleep. We spoke to them about good and bad habits for sleep, and unfortunately one of the most common bad habits for sleep is being glued to your iPhone or iPad at the end of the day. So we run them through all the things that they can do to try and improve their core sleep by making simple changes to those habits. We spoke to them about how to work through the night shift. So there are strategies that you can do to optimize how you function at night and to offset fatigue. The cartoon here is suggesting that caffeine has mixed benefits, which it does. So it's how to use things like caffeine well to get people through night shifts. One of the key recommendations that we make is that there is good evidence for people who are able to, that if you can take the short power naps that Cherry was speaking about earlier, so these are 15 to 20-minute naps, no more, that fit within a 30-minute break time that you're entitled to, that many people find that those can offset some of the fatigue and the impact of sleep deprivation on their how they feel and how they are functioning and performing. So we encourage people to be able to take those power naps as part of their breaks. We also then focused on safety issues around about getting home. And the key message with that is that if you are too tired to drive, you shouldn't. One of the things that I think we should increasingly be doing is that that responsibility should be one which is being shared between the individuals working night shift, but also the senior clinician on taking handover in the morning, who is hopefully refreshed and able to help those people make better decisions. How are you getting home? Are you safe? How busy was your night? And make sure that we're not sending people home behind the wheel of a car too tired to drive. For those who aren't driving, we talk to them about things like wearing sunglasses to block sunlight, to reduce the impact of light that will be telling your brain to be awake. And we talk to them about how to try and optimize that daytime sleep if you're working at night as much as possible. And then we speak to them about recovery, because you will all be familiar with the fact that you are now working rotas, where we'll often expect you to finish nights on a Monday morning and be back at work on a day shift on a Wednesday morning, which is the absolute minimum amount of time physiologically that you need to be able to reset your body clocks back again. So we speak to people about the strategies about how to do that and to try and make sure that you can reset yourself as best as possible. We have done that work within the London School and within Evelina London for the last 5 or 6 years. I did the session for the 4th time, I think, with our new ST1s last week. And we know from the data from our survey that just over 3/4 tell us that just having that teaching gave them enough information and enough ideas and tips for them to go and make changes to how they sleep or how they work at night, or both, that they told us they thought was useful. So something as simple as 1 hour of teaching around about this point can make some change. It's not going to transform your lives in terms of how you work at night, but it can help to make that a bit better. For the purpose of this talk, I have very much, so that is a 1 hour lecture in its own right, but that is summarized in the publication that Cherry mentioned earlier. The reference for it is there. It's freely accessible through archives, so it's an open access paper. And what that does is it's intended to summarize all of the recommendations. What it also does, though, is bring in the recommendations that I think that employers should be doing to support people, because what you can do to improve your sleep and how you work at night shift is only 50% of the equation. The people who are asking you to do that also have to acknowledge that they have a responsibility, and we should be supporting you at a systemic level as well as helping you to make changes individually around about your sleep. It ties in very much with concepts which are quite prevalent in the NHS at the moment, and these are these ideas of burnout and resilience. We are very aware, so we know that when people do even the very simple online burnout assessment indices, that many people within the health service are functioning at the edge of their tolerance already. And there is a bit of a double-edged sword about this concept of resilience, this idea that if you guys just did everything a bit better, it would all, you need to improve what you do and cope better and it will be fine. And quite rightly, there's a bit of a pushback against that. So the idea that all of the focus on this should be on the individual is completely wrong. And there must be an approach that takes into account that we need to make the systemic changes if we're going to make meaningful differences in terms of burnout and how people are able to do their jobs. So resilience can only ever be part of the solution. But one of the real difficulties is I think that people have got so used to hearing resilience being promoted as the only part of the solution that many people then very naturally react negatively against it. The lecture that I do, the 1 hour teaching around about improving core sleep and how to work better at night, it's resilience teaching, but it is not a solution by itself. We should be open to being able to do things that improve our ability to cope with the job that we are asked to do. Healthcare in general is a job that puts us at the extremes of human experience and emotion, and we're not necessarily massively optimally skilled to do that the day we start work. These are skills like any others that can be grown and developed as we go through our careers, and it's important they are built in, but only as part of a solution. The other bit of it, trying to change culture in the NHS, is tricky, and I've also been pushing, along with colleagues, both from RCPCH and the London School and elsewhere, about that quite heavily. But the difficulty is that changing culture in the NHS is often very much like this. People are very used to what they are doing already, and even when we think we can find ways for them to work better, there's a lot of resistance to changing things. And that comes out in the comments that we get in the survey when people say, no, if I'm caught sleeping at night, I am going to be disciplined. Someone's going to take a photo of me, I'm going to get into trouble. So there's a massive issue around about changing culture that we are tackling as best we can as well. As Cherry's already said, and I'll come back to this figure because I think it's a really positive outcome of some of the work that we've been doing in the London School. When we started doing this work, we focused on the how well departments supported night shift power naps, because I actually think more than anything, it's a really good indicator of how well an organisation or a department understands basic body clock circadian physiology. When we started doing this work, 15% of departments supported, and the majority were the kind that would say, if we catch our trainees sleeping at night, there's going to be hell to pay. There's always badger discharges to do. There's always work that you can be doing. There are things that you can be doing. You're not paid to sleep. Over the course of even a year, we've seen that improve from 15% to 48%. And that's by going out to as many of the departments as we possibly can to make these kind of arguments about changing. 48%, clearly we still have a long way to go, but the rate of change is really encouraging. And I think it does tell us that people are receptive when they hear the arguments to making changes. You are also protected to a degree by the contract. Junior doctors in England are now working to the new NHS employers contract for junior doctors. And obviously there was a lot of controversy around about the contract. What again I think is often forgotten is that bits of the contract were, well, all of the contract was negotiated, and bits of it are actually quite positive when we think about this. From my point of view, the contract, when it starts talking about working hours, this is the very first statement. It tells you that how you work and your ability to get protected rest are necessary to ensure patient safety, let alone your own safety. What the contract tells you is that if you are not getting what the contract says is the minimum number of breaks you should be getting, you are not providing safe patient care. And patient safety is a really important way to emphasize how significant an issue this is and how much we need to address it and drive change. The contract is also much more specific than before about what constitutes breaks and how much you're entitled to. So people working a normal night shift, which would be 12 to 13 hours for the majority, you should expect to get 2 30-minute breaks 75% of the time. If you are not getting that, you are not working to the terms of the contract, you are not providing safe patient care. The new contract is also much more specific about facilities, and it tells us in particular that employers now have a responsibility that if you stick your hand up at the end of a shift, whether it's actually a long day shift or a night shift, and say that you feel too tired to drive home, the second you do that, your employer has the responsibility to either provide somewhere where you can sleep until you're safe to drive home, or if that's not possible, they are obliged to make alternative arrangements for you to get home safely. And that is something that when we look at how widely taken up that is, we know that it is something that many trusts are still not providing, although that's improving. But just as worryingly, many people working to the contract are not aware that they are protected by this according to it. This means that things like exception reporting take on very significant importance. The only way that we will know that there is a problem is if you tell us. So even if you're within the terms of the contract, the 25% of the time that we expect that you're not going to manage to get 2 30-minute breaks, you still need to tell us about that. The only way that we can continue to make things better is by using systems like exception reporting to notify when the contract terms are not being met to try and make things better. I'm pretty clear that if everybody exception reported every missed break, what it will tell us is that we just don't have enough people in the system to provide care to the standard that the contract says we should be. But the only way we can send that message is if people engage with the process and use it and tell us. So a really simple thing that you all should be doing is regularly exception reporting when any of the conditions of the contract are not met. What can we do about it? So it is challenging. We've been doing this for nearly 6 years. And when we started, it felt like an almost impossible task. I think we are just beginning to get to the point, actually, where we are beginning to get a critical mass behind it. So in parallel to the work that I do with the London School of Paediatrics and the college, I do quite a lot of work with the anaesthetic colleges. And actually, they've put a lot in place over the last 18 months or so that started with that survey. But they've put a lot of emphasis on how they assess and manage fatigue for their trainees that they're now actually in the process of extending to their consultants, because consultants need this thought about just as much as junior doctors. And actually, so does everybody. It's not just doctors, which is a really important point about this. In terms of what we can do, I think the first step on that is working with organisations like college. The RCPCH gives us the ability to disseminate information out to everybody within our network. And I think we do have an obligation. It's a piece of work we're doing just now about how we formally extend the piece of work that we've done in the London School, which has been fully supported by the head of the London School over the last few years, how we replicate as minimum what we've done in the London School for all of the other areas within the UK. And we're in the process of talking with college about how we do that just now. One of the keys, I think, is getting that teaching in an induction. So we get this in right at the beginning of everybody's careers as well we can. So I think ST1 induction is a great point to do it. We're now halfway through. So our current cohort of ST doctors, because I've been doing this for them for the last 4 years, we now have a cohort of doctors at ST level within the London School, where 50% of them should have had this training from us at the very beginning, which I think is a massively encouraging step. It needs to be tied into campaigns that help staff everywhere to understand the importance of simple things like breaks. So within Guy's and St Thomas's, the hospital that Evelyn London sits within, we've done a hospital-wide campaign to emphasise the importance of breaks for all of our staff, and turning that back around and saying that breaks are essential for patient care, and if we're not allowing our staff to take breaks, we are not providing safe care. The college, as you will all be aware, has recently revamped its website, and myself and Serena Haywood were asked to contribute to a section on this around about well-being. So there is information on there from me about sleep and shift working, and Serena in a much more general terms about how to cope with the pressures of working within the type of job that we do, that we hope is the beginning of a conversation about how college can help to support this better. I think, as I said, the next step for us is to build on that. I want to see, this is me delivering the induction teaching for our ST1 trainees last week, and I would like to see that becoming standard in every ST1 induction in the country. We're doing relatively simple things. So our Evelina induction over the course of the last few days at the beginning of September, we gave our new doctors joining us eye masks and earplugs. It's a small thing, but it's a way of helping them to think about optimizing their sleep, particularly when they're trying to sleep in the daytime. And this is our new cohort of doctors who joined our team this week, proudly modeling their lovely multicolour eye masks. But things like this can make a difference. And actually one of the really interesting bits of feedback that we we consistently get from doing this teaching from the people who have had it is that they tell us that actually just doing a piece of work at induction that values them and is focused on them and is about trying to improve things for how they are able to function is something that they really value. And actually, I think that's also a really important message that we should be sending. The other organisations, so the anaesthetists are a little bit more hardcore than I think we will probably ever be as a paediatric college, that they have put in place over the last 6 to 12 months what they consider minimal standards for rest and culture around about fatigue and facilities. That's a piece of work that in the last 6 months has also been picked up by the BMA, and the BMA published a fatigue and facilities charter earlier this year. And between the anaesthetic colleges and the BMA, they will soon be going back to hospitals and departments and beginning to rank them and rate them on how well they are achieving on this. And I think that is one way of trying to encourage people by pointing out things they could be doing better and then coming back to them to saying, what are you doing better? And they will get to a point where they're just going to turn around to departments and say, you are not providing a safe environment for your trainees, for you to have trainees, is the intention, particularly the anaesthetic colleges. I think we probably will take things slightly more softly in the paediatric college, but we'll see. So that's the work that we've done, and that's the work that we think we should be doing. I think we will have a bit of time to take questions. We're very happy to do that. From both Cherry and I, the work that we have done absolutely could not have been done. So first of all, and I apologise, I've missed them off that slide, without the support initially of Evelina London. There is no way any of this work would have started without support from the senior exec team and the senior clinical team at Evelina London. But that was very rapidly picked up and supported by the London School of Paediatrics, which has been instrumental in getting this further forward over the last few years. And latterly, the college has been particularly supportive in getting the base to try and move this forward. So we're very grateful to all of them, and we're very much looking forward to continuing to work to try and bring this work and embed it to as many paediatric training programs as possible. I'll leave this slide up while we deal with questions if there are any. This is just a link to some references that give you some more information about the things that we've talked about. Thank you for listening.
Thank you, Mike. That was really great. And thank you to both of you and Cherry for a really interesting and very detailed presentation. We do now have about 20 minutes for questions. So those of you that are listening in the ether, could you please send your questions through the questions tab on your screen? And we'll ask Mike or Cherry to deal with them as they come through. While we're waiting for questions to come through on the system, I have one question that's come through actually from a member of staff at the college, so I hope you'll forgive us asking a question of you. It's around the evidence base for using melatonin as a sleep aid to ensure good sleep and transition between shifts. Do you have any?
So the first thing to say about that is, so melatonin is a prescription-only medication in the UK, and while you can obtain it via the internet or abroad, you have to be very careful about obtaining medicines in a way that is not seen as above the board. So the GMC have in the past taken a very negative view of doctors in this country who have obtained prescription-only medications from other countries via the internet. Now, to be fair, that's usually more significant medications than melatonin in many ways, but you have to be a bit aware about that. The second thing is that melatonin is a medication, and although it is sold as a healthcare supplement in other countries, the reason it's not in this country is because if you use melatonin wrongly, you can actually cause problems. And the other thing is that when it's sold as a healthcare supplement, it's not very well regulated. So if you buy a 2 milligram tablet of melatonin as a healthcare supplement, you might have 0.5 milligrams in the tablet, or you might have 10 milligrams. It's not very well regulated. The third point is that if you are thinking about using a medication for a sleep-related reason, you should see a doctor. Now that needs to be either an occupational health doctor in your clinical team or your own GP in the first instance, and it absolutely should not be yourself or a friend. You need an independent view. If you think that your sleep problem is serious enough to need a medication, then you should be talking to a doctor. The role of melatonin, there is a role. So before you can think about using melatonin, what melatonin does is to help maintain or support good core sleep routine and habits. And what that means is that melatonin will not fix your Netflix addiction. You have to focus on getting that core sleep routine and habits right first. And actually, for the vast majority of people, doing that bit of work, which is hard work, but it is what is going to really improve your sleep is the thing you need to do first. And only if you have done that and you still think you have a problem is when I would be recommending for most people to be thinking about taking that to the next step. If you do that, then where I think the role of melatonin, particularly for people working shift work, is to use it when you're trying to re-establish your normal sleep pattern at the end of shifts. So when you're doing that piece of work that we talk in more detail about when we do the full induction teaching about resetting your body clock back again, as you come back into your normal sleep routine, you can use melatonin to try and anchor that back in place again. I wouldn't encourage people to use melatonin when they are working night shifts, because actually it's quite easy to start using melatonin at the wrong time that will actually cause you problems. But there is probably a role for helping to re-anchor it when you come back off night shifts. And hand up, I did that when I was a registrar, partly because I knew what I was doing with melatonin, to be fair, although I shouldn't have been self-prescribing. So yes, there is a role. Yes, there is a temptation because it can be bought over online, or if you nip across the channel to France or whatever. But I think you do need to think about it, and you do need to be doing that piece of work around about improving your core sleep routine and habits first if you're going to get the most benefit out of it.
Thanks, that was really helpful. We have a couple of questions that have come through. The first one is relating to night shifts. Is it possible to limit the number of continuous night shifts to 2 or maximum 3 in a row to reduce fatigue? And if so, will it be useful?
The simple answer, I'm afraid, is no. One of the big difficulties about all of this is that sleep is a very individual thing. And although when I do this kind of teaching, I talk in very general terms about things that I think are good for sleep and bad for sleep, which are pretty much true for most people. But everybody sleeps in a way that is individual for them to a degree. So the example that most people are familiar with would be that you can be a morning lark, so you're quite quick to get up in the morning, you feel refreshed and ready to go, but then you're probably going to be somebody who goes to bed relatively early when it comes to nighttime. Or you can be an evening owl where you're really difficult to drag out of bed in the morning and you do your best work between 10 o'clock and midnight. And if the difference in that, so people, you will not be surprised to learn, if you happen to be an evening owl type person, you probably tolerate working night shifts better than if you're a morning lark. When it comes to shift patterns, there isn't a one size fits all. Split, so 3-4 nights, the kind of split nights that have evolved over the last 10 years is probably the best compromise for the most people. But one of the really important points about all of this when you're thinking about working at night is that working at night at all is unnatural. Your brain and body expects to be asleep at 3 o'clock in the morning. Every aspect of your physiology is screaming at you that you should be asleep. So there is no good way to work with that. There are only less bad ways, and everybody's individual less bad way is slightly different. To illustrate that, I guess, so I was somebody who, when I worked night shifts, I worked a whole range of different night shift patterns, from 48 hours on call to 14 nights in a row to 7 nights in a row to 3 nights in a row to a single night in a row. And what actually worked best for me was 7 nights in a row, because I can flip my body clock. And by the time I got to day 2, day 3, I was pretty much nocturnal, and I'd flipped my body clock and I was fine. If you can't flip your body clock, which lots of people can't do, by the time you get to night 6, night 7, you are just completely, at the most extreme, you might not at any point in you being there at all. But because there is that huge individual variation, it's really difficult to say this is the single answer. Every rota should have this pattern. It just doesn't work. So there needs to be a bit of thought about it. There are simple things. So rota patterns should do things like move from a day shift to an evening shift to a night shift, because that's the way our body clocks roll. So if you try and go any other combination of that, it will not work as well. But yeah, the 3-4 night shift split is probably the least worst compromise for the most people, if that makes sense.
Thank you. The next question is about the induction materials. Are there any induction materials available to use for the induction of junior doctors in other departments?
So those of you who have seen me talk will be aware that my slides generally need to have me to make sense of them. However, if you and I've taken it off that link because I replaced it with the RCPCH one. I can send Sarah along a link to send out. On the Guy's and St Thomas's Medical Education webpage, there is a downloadable short induction presentation. So it's only about 5 or 6 slides. And what it's intended to be is a 10-minute induction presentation that can be delivered by anybody. There's a suggested script. And what it basically is a curated list of resources to show to people. So it shows, so the top left-hand corner of your screens at the moment, for example, is a 15-minute video of me doing one of these talks. The top right-hand corner is the 10-minute BBC Inside Out South report that talks about these issues. And the bottom left corner is the archives article that has all the practical hints and tips. So what I encourage departments to do is to either build in a 5 or 10-minute induction session that signposts to these, or if they have half an hour to spare, what they can do is just show those two videos and say, here's the paper to go away and read, and that will give you a 30-minute induction session on this topic. For those of you on Twitter, pinned to the top of my Twitter timeline is a tweet that has the links to those resources to be able to do that. So yes, there are. One of the bits of work that I am hoping to be doing with the college very soon is using the new college wellbeing and sleep web pages to have those resources approved by college and able to download for people from there. But we still are in the process of doing that piece of work, but you can get it from elsewhere at the moment.
Thank you. I have a question come through which may need slight interpretation based on how it's written. In the long run, for example, in 5 to 10 years, do you think there is a value of reducing work hours and increasing number of staffs? That may mean shifts rather than staffs. For example, 6-hour shifts for 5 days a week.
Yes, but it doesn't need to even be the long term. We know fundamentally we do not have enough doctors and nurses and healthcare professionals in the system to do the job that we need to do. We need more staff. Very, very simple. There are health and safety executive recommendations about night shift working, and the recommendation for night shift is that nobody should work in a stressful, high-pressured environment at night for longer than 8 hours. We are exempt from those because neonatal intensive care or pediatric intensive care or ED are not classed as being high pressured or stressful enough, clearly. It's a slight joke. There are other reasons why we don't follow that. But the immediate difficulty in doing it, though, is that if we cut our shift lengths right now to 8 hours and said this is better, there are still going to be the same number of people in the system. So all you would end up doing would be working night shifts a third more than you do now. And nobody is going to thank us for doing that. But yes, we should be making that point. We should be saying that we know that function and performance is impaired, particularly at night, particularly when shift lengths go beyond 8 hours, and we should have longer term solutions in place to do that. But it then becomes very political and relates obviously to funding of the NHS and provision of those places. But yes, from a pure physiology point of view, we should be. In the shorter term, there are other things that can be done. So there's a brilliant piece of work that's been done by a professor at one of the University of London colleges called Celia Glass, who is a business professor by trade, who is working with the emergency department at the Whittington Hospital to do individualised rota. So what they have is a system where individuals plug in their preferences, and they can be as relatively specific as they like. And what the system then does is try to create an individual rota over a 6-month period that fits as many people as possible. So it does things like, so people going on holiday far enough to be jet lagged, it rotates them through shift patterns in the few days before they're due to go on leave that starts shifting them towards the time zone that they're going to on holiday anyway. And then when they come back, they're rotated onto shift patterns that will adapt back the other way. And I think that kind of work is something that in the longer term we probably need to be looking at. Professor Glass is looking at the moment with a number of other organisations about expanding that, and I think that that kind of more intelligent approach to rota design is probably going to be the next step at that level in thinking about this. But ultimately, yes, we need to be thinking about shorter shifts. Some specialties and some departments do, so there are very definitely emergency departments up and down the country where the longest shift will be 8 hours. So some already are, but it comes back to staffing and resources.
Thank you. We have one more question through. Would you be able to provide a teaching session about this topic in one of the paediatric teaching external weekly slots? I think that may be a personal invitation to
yeah, sorry, I'm not quite clear what I'm being asked to do there. Sorry. Who's it from? Depends where they are, to be perfectly honest. I spend quite a lot of my time doing this, and I'm not well, not that I'm not paid to do it, but it's not in my job plan, which means every time I do something like this, I have to cancel work that I then have to make up in other ways. So yes, I have done lots and lots of teaching sessions about this over the last few years. Feel free to email me and I can see if I can work something out. But there are resources there, and actually one of the things I hope that the college work is going to do is create people up and down the country who are confident in delivering the type of teaching that we've done at Evelina London, because much as I love doing this, I can't go and do ST1 induction in every deanery in the country. So we're going to have people who are able to deliver this type of teaching up and down the country. And those people exist. We just need to persuade them they need to do it. So get my email address from somewhere or look at my Twitter account, and I'm more than happy to do it if I can. So no promises.
Thanks, Mike. I think we've come to the end of the session now. No further questions. So again, just a really quick thank you to both Cherry and Mike for a really interesting presentation. If there are any questions that you have that you haven't had the chance to answer or that occur to you after the session, please do email them through to me, sarah.fellows@rcpch.ac.uk, and I'll route them through to Mike and Cherry for a response. And again, as mentioned at the start, if you have colleagues who weren't able to join the webinar right now, we have recorded it and it'll be available online in a few days on the RCPCH Compass website in the webinar section, so do take a look when you have time. But that's it for today, so thank you very much and enjoy the rest of your afternoons.